An honor it is to be here today. I want to give a special thanks to Rashmi, John, and everyone else who made today possible. Again, my name is Frank Giamie. I'm Ella's father. This is Dr. Radhakrishna, Ella's pediatric rheumatologist. I wish I was here today to tell you about all the accomplishments and the places Ella has been, even dealing with this difficult disease, but that's not where we are at today. The story I'm going to tell you is only a small part of a bigger story. Today we're going to talk about Ella's story as it pertains to sJIA. And in her passing, it's occurred to me that, a lot of times as adults we measure our lives by the number of years we live. And it's occurred to me, but maybe we should start measuring it a different way. Maybe we should measure it by the number of people we impact, or how about the number of people we inspire, or how about the number of people we influence for the better. In Ella's short life, she was able to do just that, and that is why we are here. Before I begin, I want to direct your attention to this quote that I read from Sheryl Sandberg and Adam Grant. This came from the book that they wrote together called Option B. It says, "Not only do we learn more from failure than success, we learn more from bigger failures because we scrutinize them more closely." It's my hope by acknowledging the failures that we have fighting this disease, that it strengthens our resolve to help children like Ella. So with that, we'll get into the presentation. So Ella was born on a Tuesday, 8:31 a.m. She was healthy, perfect. She came out of the womb looking like me, had the same dimples, about the same amount of hair. She was beautiful. We were good. We had an older daughter. This picture on top was taken in April of 2012. She was 8 months old there with her sister Ava. And life was good. On her 4th birthday, we were walking in the neighborhood, and my wife noticed that she had a rash on her thigh. And she asked me, she's like, "Frank, where could she have gotten this?" I said, "I have no idea. We were camping that weekend." So I said, maybe she was rolling around in the dirt, and that's what the rash was from. So we kind of dismissed it. We kept an eye on her, and then she started having a fever, and then the rash came back. And it was kind of concerning. She woke up on a Wednesday morning, and she had her appointment with her pediatrician, and it was her 4-year-old wellness checkup, and she had a limp. Her knee was bothering her. And I said, okay, well, it's good. At least we have an appointment with the doctor, and the doctor can tell us what's going on. Our pediatrician's fantastic. She was really concerned. She said, let's do some labs and just keep me posted on what's going on. So checked her up. That was fine. And on a Friday, she woke up in pain, obvious pain, and she couldn't walk. So I carried her downstairs, and I called the pediatrician. It was like 7:30 in the morning. I said, something's wrong. You need to see her, and we got to figure this out. So we went in, and we went back to the clinic and did another set of labs. She said, I'll call you once I get some results. So we got a call about noon on a Friday, and she said, I booked you an appointment in the emergency room at Children's Hospital in San Diego. So of course, we're concerned as far as what's happening. So we get admitted into the hospital, and we went into the ER, and that previous photo here is actually her in the ER waiting to be seen by the doctor. So we get admitted into the ER, and we were told that she has a septic joint. So we're like, okay, septic joint, we can deal. We're going to aspirate the joint, and antibiotics in a few days, we should be good. Well, that's not what happened. So they aspirated the joint, nothing grew from the culture, and they treated her with antibiotics, but her condition remained. So the fever, the rash, the joint, well, obviously the joint pain. So they said, sometimes we don't get it on the first time. So let's go in and we'll do a second aspiration. or they did an MRI first to double check, and then they did a second aspiration. So this poor kid in 5 days had 3 procedures where she was sedated. And we were trying to figure out what was going on. So initially, infectious disease and ortho were working the case together. And it was funny because the first day that we were inpatient, the infectious disease doctor said it could be a myriad of things, but more than likely it's a septic joint, but it could be this thing, you know, it could be JIA. I said, well, tell me everything that it can be. I've got my laptop. I'm going to read as much as I can so I can understand. I don't have a medical background. So every term that they were telling me was foreign to me. And eventually, by about a week into being in the hospital, ortho brought rheumatology, Dr. Sheets, to examine Ella. We gave him the story. And he said, you know what, I think you have sJIA. So, okay, well, good. Now we have something that we know we can treat and deal with. And he cautioned me to having, you know, that thought because of the difficulties associated with this disease. So she started steroids, and after about 7 to 9 days, that bottom picture is the day she was discharged from the hospital. We rolled her out in the wheelchair, and what an exciting day that was for us. So here we are hoping for remission. We are on half doses of anakinra, daily injections. This photograph here was taken in Hawaii in January of 2016. The drug was working. We were tapering off. We were going to half doses. The shots are painful, as you guys all well know. It's not necessarily the needle. She took the needles like a champ when she's doing blood draw, but it's just the pain from the preservative in the medication that causes some trauma associated with it. And we were really focused on remission. At this point, I was reading as much as I could on the internet to understand this disease. Where are you? Where's the medical community at as far as research, and how do we treat this, and how do we beat this thing? And we were fully committed, as you can well imagine. So in March of 2016, Ella came down with a strep throat. And that's when some things started to happen that we couldn't understand. She had a non-sJIA rash. If you look at the top 2 photos, the redness and swelling in her eyes and the top of her back is raw because she would scratch it raw. Her belly, she ended up getting cellulitis of her belly button because she had such a sensation to itch there that she caused an infection. So we had to go to the urgent care, and we got a prescription of Keflex, and she was on it for about 8 days. And that's the photo to the right after about 8 days of being on the Keflex. Again, like I say, I don't have a medical background, so I'm not sure. But from everything that I've read, I'm trying to put my thumb on it. I thought it might be serum sickness associated with the medication. Her disease, continued to persist. She would continually have flares of rash and fever, and so we decided to increase her dose of anakinra to a full dose every day. Well, as time went on, here's July of 2016. Her inflammatory markers had worsened, and so we were obviously concerned. And did she build antibodies to the IL-1 blockade? Do we need to move to a different drug? She was CMV positive. She tested positive for CMV, and we tried to move her onto Actemra. The first time that she was infused with Actemra, she had a terrible reaction that landed us in the hospital for a few days, trying to control the disease itself. We thought it was an allergic reaction, so we tried it again a second time, and only to have the same results. She really had the uncontrolled body shivering, pale and dusky skin. It was obvious she wasn't doing well. Again, she was hospitalized, had a high CMV count, and we started the ganciclovir. We returned to anakinra, and then we wanted to get on the steroids. Dr. Radhakrishna's concern was, let's control this disease. We don't want it to get out of control, which, of course, we concurred, and we wanted to have Ella feeling better again. So August of 2016, we're on high-dose steroids, and our concern was getting Ella back into school and just being a normal kid. And I think as a parent, that is the push-pull that you have, is you want your child to be normal and be like every other kid, but you've got to balance the risk associated with this disease and getting infections, and especially when they're this small. Elementary schools are a ripe of germs. So we were focused on getting Ella back to school. We were on daily anakinra, and we tried to do a long taper and wean her off her steroids. The photographs that you see to the right was the first day of school last year with Ella. She was born on the 30th, so this is about a week after school started, on her 5th birthday, and the one on the left is Halloween of 2016. She was doing well. We were cruising, and we felt that we basically accepted the fact that she was going to be on daily injections for the rest of her life, and that we're committed to her, and that's what we're going to do. Then in December of 2016, the injections became difficult. So the site injections became hard. They were painful for her. So we talked to Dr. Radhakrishna, and we said, hey, let's try switching to Alaris. Once a month, it's an IL-1 beta blockade. It may have a better effect on her, and we don't have to give her the daily shots. For those of you who do not, who haven't dealt with that, having to hold your child down to give them a daily injection is quite the task, and it's every morning you have to do this. And to even think that maybe we're going to do 2 doses a day, to do it twice a day, it's quite the chore. So the day after Christmas, Ella comes down with a high fever and a cough, and we take her to urgent care, and she's diagnosed with pneumonia. Despite the antibiotics that she's on, she's still having daily high fevers, and her ferritin levels are rising. Again, we said, okay, we're not going to risk it. Of course, you got to play that game too with the insurance company. So if you got a daily injection of Alaris, do you have the anakinra if it doesn't work? Dr. Radhakrishnan and his staff were fantastic. They always made sure that we had medication on hand. And when the Alaris failed, we used the anakinra, and we're like, okay, we're not going to try that again. Let's just stay on something. Unfortunately, it hurts her, but we don't have really a choice. But then this is when the complications began to add up. And we started asking ourselves, does Ella have a refractory case of sJIA? The pictures that you're looking at, she's got an abscess behind her left ear that appeared overnight for some unknown reason. I had no idea why. She had swollen lymph node glands underneath her armpit that Sandra had discovered, I want to say in late January. She complained of stomach pain. Her chest x-rays continued to be abnormal. And in February of 2017, we went back into the hospital inpatient, and her ferritin levels again were elevated. We were on the same routine. I had taken my laptop into the clinic or into the hospital, and again, I'm reading as much as I can. I found the sJIA Foundation, actually found a presentation made by Dr. Khanna about IL-18 levels and whether it's a refractory case or not, and I asked Dr. Radhakrishna, we need a test for that. He said, there's no commercial test available. I said, well, if we need to know if she's refractory, because we've got to put all hands on deck here and get ahead of this before it gets out of control. Now, I was aware of MAS. I understood the complications, and 4% mortality is what I read in some of the articles. And I'm like, I want to stay as far away from that as possible. And so we talked about it. And he says, listen, we're going to combine the therapy, and we're going to stack them with anakinra, tacrolimus, and stay on the steroids. That was our full court press. Then March of 2017, Ella, unfortunately, she would tire easily, and I couldn't figure out what was going on. We were playing softball at the time, and we'd get the kids to run down to first base, and she would saunter, and I'm like, come on, Ella, hustle up, and she would take this deep breath and then exhale. Well, looking back, hindsight is 20/20, right? And we're talking about lung disease and lung complication. I just thought she was tired, which could be a general symptom of this disease. April 3rd of 2017, she had an ulcer on her tongue that we thought was like a canker sore. Had no idea what it was, and so we treated it as such. She was taking an iron supplement because she was anemic. And we had an appointment with Hem-Onc on April 4th, which was a Tuesday. And I went to work, I'm working, and I get a call from Sandra, who went to the hospital and says, Ella's not doing well. I don't know what's going on. Her face is completely swollen, and her tongue is thickened like to twice its size. I said, I'll be right there. So I drove from work to the hospital. And, I'm like, I'm glad we're here today. We can address this, fix this problem, we'll move on. Her tongue continued to swell, and they were concerned that it was going to compromise her airway, so they intubated her, which, I don't know, as a parent, watching your child be intubated is a scary thing to see. And Sandra was a little concerned, of course, but we were in a good place. Competent doctors who really cared, and we're going to fix this, and we're going to put it behind us. They couldn't treat. They thought there was some allergic reaction to her tongue, so that wasn't responding to any medication or anything that they had known to treat angioedema, and they ended up doing a biopsy of her tongue. And turned out it was staph, and the tissue there was necrotic. Fortunately, it was a Friday. We were in the hospital, and someone had recommended that I attend a talk, and they were just talking about this very thing, the complications of sJIA and a few other rheumatological conditions, and discovered that Ella had PJP. I had never heard what it was. Again, I read about PJP and how it associated to the AIDS epidemic in the 80s, and it was a major killer of AIDS patients. But once they identified it, they were able to treat it, and to seem that we had some better outcomes. Again, I was confident that we were going to be able to treat this and move ahead. At one point, Ella was successfully extubated, and things were fine. When I say fine, she was talking. Of course, being intubated for 8 days, her lung capacity was nil, and we were trying to do we do the laps around the pod to try to build up her strength. She was using the spirometer to try to build up her lung strength. We got downgraded from the ICU, the PICU, into a normal hospital room, and then that's when the swelling started to return, the fevers and the shivering, and obviously something was wrong. So the intensivist came down and saw her in a room and says, I think I'm going to bring her back up to the PICU, and we're going to have to intubate her again. She was taking on so much fluid that we had to put her on dialysis, and it was clear that she was in full-blown MAS. And as a parent, you're kind of in denial, right? Because this is the spot that you've been trying to avoid, doing everything possible to stay as far away from this. And even with everything that the doctors were doing, we still arrived here. And I don't want you to even think that, I questioned the treatment or we questioned the treatment, because we didn't. We know everyone was doing their best. So I thought we were doing a full court press. Well, now we really are. She was receiving high doses of anakinra steroids. She was on plasmapheresis, IVIG, and I was told about a novel therapy for IL-18, an interferon gamma blockade, and I said, okay, let's see if we can get it for her, because we're starting to run out of options, and I understood what that meant, and that we were approaching the point of no return. For those of you who haven't been in a hospital, and when they're doing lab draws every 4 hours and you're hanging your hopes on every 4 hours around the clock, it's difficult. It's tough because you're hoping and you would get a mixed picture. Well, some things are better, some things are worse. And so here you are, you're stuck in the middle. Dr. Radhakrishnan in February had ordered a genome sequencing, have her whole genome sequence, and it came back negative as far as having some gene mutation that we could maybe treat more directly. And then I think it was a Sunday, or was it a Wednesday? Doesn't necessarily matter, but she started to have a GI bleed. And this really sent the PICU for a loop and was out of left field. This wasn't anything that any of the doctors in San Diego had ever seen. And pressure started to build in her abdomen. She developed abdominal compartment syndrome and wasn't really given much of a chance to live. The PICU doctor had sat us down in a small closet of a room that the social worker works out of, and it was Sandra and myself, and I called Dr. Radhakrishnan. I'm like, you need to come right now. We need to talk this thing out, and we need to decide what we're going to do. And there we are sitting in the room, and we're doing this back and forth. Do we do the operation and relieve the pressure in her abdomen, or do we try a chemotherapy agent, etoposide, and try to treat this disease? And unfortunately, what we were doing already wasn't working. So, you were basically faced with two terrible choices, neither which being good, and then trying to figure out which one was going to save her life. We decided against doing the surgery, and we hoped that the etoposide was going to work, and maybe we could get the novel therapy, and then unfortunately her organs began to fail, and then on May 1st, that's when we had to make the decision to take her off life support. The most difficult thing that Sandra and I will probably ever deal with in our lives. But, we're here today to tell her story, not just to all of you, but, to the medical community to understand how difficult this disease is. And hopefully her sacrifice is going to further research and again, the resolve that you all have in trying to treat this disease. I'm going to turn it over to Dr. Radhakrishnan. I know he wants to give a little intro.
Thanks. Yeah. So, before I begin, I just want to thank the organizers of the meeting. Rashmi, what a fantastic job you've done in creating this organization and bringing everyone here together. We really appreciate that, and it's very inspiring. And I also want to thank Frank and Sandra for everything throughout this time that we spent together. You showed incredible courage, exemplary love and dedication, and just really inspire me on so many levels. And it's just incredibly brave for you to be here today, so soon after her passing, and to dedicate yourself to this cause. So I appreciate you being here. And I also want to thank those of you in the audience that we contacted along the way, as Ella wasn't doing well, we'd reached out to many of the experts in the country and internationally as well, and really do appreciate everyone's sincere help. And it really speaks to the way the pediatric rheumatology community works, that we could contact each other and reach out to one another in these times of difficulty. So I do appreciate all of that and the work that everyone's doing here to improve the care for these children. So Frank came to me only a few weeks after her passing and said that he had raised some money and that he was really motivated to try to improve the care, and asked me to come up with sort of a wish list. What things could we do in retrospect, looking back at different intervals? Where could we have possibly improved the situation? What kinds of information could we use in the future for children like her to change the course? And in our course of our discussions, we came up with sort of a wish list. And that's kind of the framework that we use for this talk. Now, we want to present this wish list, but clearly none of these things are really that revolutionary, and everyone here who's had many years of experience has crossed these bridges before. So the point is not necessarily to bring up these ideas as novel, but really in the context of Ella's story, lend a personal side to it and speak to the urgency with which we want to see these advances happening. And it's really inspiring to see posters like the ones that we have here, and we look forward to learning from all of you about the advances that we're making in this condition. So looking back at the time of diagnosis, what kinds of information could we have had? First of all, although it's probably beyond the scope of sJIA Foundation, clearly an earlier diagnosis may help in certain cases, especially when there's not a lot of pediatric rheumatology support. So increasing the awareness among hospitalists, ID specialists, and orthopedics would certainly be helpful. Frank and I have even talked about, from a patient perspective, maybe we ought to be changing the name of this condition, as even in the beginning of this talk, we had some confusion about what sJIA is. How do you actually pronounce it? What does it mean? Perhaps from a patient standpoint and a public standpoint, another name would be helpful to characterize this disease better in the minds of the public and draw more attention for fundraising. And beyond that, once we've established a diagnosis, as Rashmi alluded to and as many of us know, clearly we're dealing with different subsets of children. So what sorts of tools can we use to characterize those better? This is one of the most important things to me, I think, as a clinical rheumatologist. How can we tell a family what sort of risk they might face? We at our institution went through our Genome Institute in February when she was starting to accrue these infections and made the pitch for getting whole genome sequencing. And it took almost 2 months to get the results back, at which time she was already in the ICU and in very critical condition. And was told that there was nothing actually valuable found out of that, which perhaps on a deeper look might be valuable. And so Dr. Umbrella is looking at me like, really, is that the case? And so certainly it would be my wish that we could get this type of sequencing up front and perhaps work with doctors like Dr. Umbrella to really delve deeply and understand what some of the factors might be. And likewise, can there be a panel of tests beyond the routine, such as gene expression studies or cytokine profiles, that can help us better understand what level of risk we're dealing with? So now moving on to the point of remission, actually, in fact, Ella did do really well for the first 6 months on anakinra, off steroids pretty successfully. But then when do you ask the question of when can you remove the therapy? And I see a poster up here talking about, I think, tapering as early as 3 months into their course. So when can that be done safely and when can that not be done safely? And what sorts of studies can we do to prove that we're actually still in remission while we taper off? The question also arose about anakinra's efficacy or perhaps a possible reaction which is causing a rash. So as a clinician, how can I tell if anakinra is actually working and I just need to maybe step up the dose, or do we need to abandon and shift gears? Now, as things got more complicated, clearly infection became a problem. And we always felt like we were behind the 8 ball on this. We were always catching up to it. And CMV in particular, we had conflicting labs telling us one hand it was negative, on the other hand it was positive, and it took us months before we could, maybe weeks, before we could actually establish that indeed CMV was playing a role. And even then, insurance was not covering ganciclovir as an outpatient because it wasn't indicated for this condition. It wasn't even known about this condition. We had to go back and forth about this. So certainly we have some new studies, new technologies like the quote-unquote digital cultures or sort of fast sequencing for multiple thousands of organisms. And that sort of test became available at our hospital 1 week after she passed. And certainly we'd love to see that kind of thing come into clinical practice much more quickly. Many people have talked about lung disease and surveillance. Perhaps that's something we should have considered at an earlier stage. And then the question of antibiotic prophylaxis. At what stage and for whom? And which drugs are we talking about? All are important questions that we want to try to answer. Frank and I have also discussed the concept of refractory, and maybe perhaps defining that formally, although we all have an innate sense of what that means, perhaps defining it formally would help, especially families and others, to know when perhaps we can define whether children would be more eligible for other studies or other therapies. So having a more formal definition may help. And Ella, like some others that we've heard about throughout the nation, experienced a very significant reaction to tocilizumab, a very bizarre reaction that we hadn't seen before. And that seems to be some sort of a marker. And I know that there are people working on that, and I think that's an important area. So as we came into the time of MAS, certainly we called upon many of you in this room individually for help. And I think it would be nice to start to conceive of perhaps different levels of expert teams within a hospital, a local expert group, as I believe is being done at Boston Children's and other institutions for MAS specifically, composed of people from different disciplines. And then perhaps at a regional level, other groups, and perhaps at a national level, some sort of maybe more formal structure for people to get advice and opinions on their cases that are difficult. I know everybody's doing it out of their own free time and in between things, and I think that that's wonderful. If we can, perhaps, I don't know the logistics of it, make that more formal, that may be helpful. And clearly in Ella's case, really time was of the essence. And the trouble for the clinician is how do we choose among all these new options? And as we introduce more biologics, how can we have an idea of which one may work better? In our case, we went a more traditional route with a calcineurin inhibitor. But speaking with Dr. Krohn, we heard about abatacept as an option. Really, we would love to know how can we better choose? Or is it rather better to go for a transplant? Those questions really need to be answered, and a lot of focus of this meeting will be on those novel therapies, and that's something that we really look forward to learning about. And perhaps MAS, as we've seen, is a different entity and needs specific therapy for it. In addition, I thought about the concept of the coagulopathy that developed, the severe GI bleeding. That became very unmanageable, and maybe there are other avenues that need to be pursued along the lines of treating the coagulopathy itself. So these are just our reflections, our thoughts from the case. I'd love to speak with you and hear your thoughts as well. We're here to learn and to share ideas. And we really look forward to this meeting and appreciate the opportunity to speak about Ella's case, and applaud all of you who are doing so much great work in the lab and in the clinic to help these patients. So thank you again. And Frank is going to just summarize a little quickly on his thoughts.
Thank you. So what do we do now? I mean, it's clear to me what Sandra and I are going to do. We're going to be advocates for these patients and the parents that deal with this disease. It's such a difficult thing to deal with, the daily process of trying to treat this disease and the ups and downs with it, that parents need support. We want to challenge the treatment process, is what Dr. Radhakrishna alluded to, and try to think of better ways that we can treat these children. Again, as a caregiver, what does refractory look like? So you know exactly, hey, you're in an area in which you don't want to be, or it's about time you have a in-depth conversation with your doctor. Again, we want to early on attempt to identify kids that are potentially refractory. I know there was some discussion about the presence of IL-18 cytokines, and these children are more likely to have MAS. I think that's an excellent tool for the clinician to have, to know, say, listen, we're kind of heading down in that avenue that is going to make it make their course of treatment much better. Again, identify lab tests that may indicate MAS risk, and link clinicians with research scientists. I know the process of publishing and the time it takes to get articles reviewed, published, and disseminated. But if you guys can have the discussion between clinicians and researchers to say, this is what we're seeing in the lab, look at your patients and keep this in mind, and kind of foster that discussion. As we talked about before, develop a multi-specialty center of excellence dedicated to sJIA throughout the country. I know there's some states that don't have pediatric rheumatologists and that would need somebody to refer to. Geographically, if you had 5 or 6 centers throughout the country, say, listen, you're having a child that has this disease, these are the people who you call. These people, they're here. They're here in this room right now who have the insight and can share the information. Just knowing where to go is important. And again, we have to be hyper vigilant about treating lung disease and improve that treatment process. It is it's kind of the ghost that you're fighting, because you don't know exactly. You're so focused on treating the rheumatological condition. I know you're worried about infections, but when Ella was diagnosed with PJP, ID was shocked, and so getting that information out there and teaching these infectious disease doctors, and maybe even bringing in a pulmonologist and saying, hey, this is something you need to have on your radar. We've got all these specialties in the hospital, but this is one more thing that you're going to have to be concerned with, and start delving in, because maybe from a pulmonologist's perspective, they're going to think of something that maybe an infectious disease doctor or a rheumatologist is not going to think of. So this photograph was taken probably 30 minutes after she passed. Those are all our hands together. This is the life that we have to live, and it's difficult for us to see this for other children. I hope we make a difference. I hope we are committed to this, and the resolve that we have are thinking about these little children who have a life to live. Thank you.